Welcome back to the Chatty Vets pod. I'm Brendan.
And I'm Charlotte. Thank you for tuning in.
Welcome to our last podcast of May, our extra bonus episode.
We have spoilt you again this month, but honestly, we needed you to hear this podcast. We have been so excited about releasing this episode. We just couldn't wait anymore.
Absolutely. We just had such an exciting interview with Russell a couple of months ago. We've been sitting on it for a while now, but we felt it was time for you to hear this.
Yeah, absolutely. So we sat down with Russell Chandler in March this year and chatted through all things regenerative medicine. Now, being honest, before we met with Russell, I wasn't super interested in the topic. I didn't really know much about it. I felt like it was a bit of a fairy tale, like it wasn't really something that was happening in practice and that we weren't really quite there yet. And it was all a bit, I don't know, airy-fairy in terms of the medicine behind it. But I sort of went into the interview with a bit of hesitation, not really expecting loads, but I was so wrong. I absolutely loved it. What did you think, Brendan?
Yeah, I mean, it just brought it home. It just made it feel like this is something we can all get going with. And I love the way that they're doing it. So, yeah, it's definitely opened my eyes. And I think putting a face to someone who does it just makes it feel more credible, because in the past you just hear these stories and you feel a little bit like it's just some strange lab people from nowhere.
I think it's just made us realise that regenerative medicine is now a field of medicine in vet med that is becoming more real, and it's becoming something that can really be done day to day in general practice by all of us. So yeah, maybe we should get into it a little bit more.
Yeah, and wait for your client. I had a client ask me about it about a month ago, and I was like,
No way.
I don't think, yeah. Do you know, I think what's happening is they're doing AI or whatever, and they're hearing about it as an option. So then she brought it to me, and I actually just said, I don't know, I don't think that's a thing yet. And she was like, oh, thank you for telling me that. And now I feel, then we had the interview with Russell, and I thought, oh no, actually it is a thing.
Yeah.
So it's been really eye-opening to.
So if you're listening to this and you're thinking, what the hell is regenerative medicine? You've got absolutely no idea what we're talking about, then we'll dive into it right now. So we'll hand over to Russell to chat about everything chronic pain, regenerative medicine, and we really hope you enjoy listening just as much as we enjoyed chatting to him. Here we go. So if you can, then give us a bit of a bio about you. Tell us who you are and what you do.
So as we were saying earlier, Charlotte and Brendan, I've had quite a varied career and a very fortunate career, I feel. I graduated from Bristol back in 1987. Sounds like a long time ago, but it's kind of flown by. I first went into mixed practice, as a lot of vets do, and that was good, but it wasn't really my niche. So I kind of wanted to get a little bit better at a certain, part of the profession. So then I went into small animal, where I could indulge my interest in surgery, really. So that was better for me. But then due to circumstances at the time, and we're talking about 1990 to 91, the economy was terrible, and I was kind of forced in a way to look for a different geographic location, I suppose. So I ended up applying for a job in Hong Kong. So my wife and I went to Hong Kong, and this is in the days before the internet. So it was almost impossible to find out much information about the practice where I was going, about what the clients would be like. So I was very much dropped myself in the middle of Asia, and it was a kind of a sink or swim situation. Fortunately for me, it was a brilliant baptism of fire, but it really allowed me to develop and cut my clinical teeth, because there were so many challenges and differences there, and frankly, so much work. The caseload was unbelievable. It really allowed me to accelerate the career development in the area of surgery. So I didn't know what kind of surgeon I wanted to be, but kind of the situation determined that there was a deficiency for people who did fractures, orthopedics, spinal surgery, that kind of thing. So when I started doing my first spinal surgery, very quickly, the small veterinary community found out about this, and then all of a sudden I was getting referrals. And this was not what I planned, not what I set out to do, but because there was somebody who was apparently doing spinal surgery, then that meant that there was a referral possibility for the first time in Hong Kong.
So what this was the 90s, was it?
That was 1992,
92.
3, 4 and 5.
At that point, I don't think a lot of people in the UK know what veterinary practice is like in Hong Kong. But I know one of my friends has been there for the last 20 years. And am I right in saying, well, he says, I think there's a lot of very committed owners that will just go as far as they can go. Was it like that in the 90s as well? Or is that a true picture?
I think that is a true picture. At the time, it was developing. Pet ownership was very, very new. So we had a very naive population of pet owners, and it was growing exponentially. So trying to keep up with the amount of work was tough, and then developing that into something that resembled the kind of work that we were used to in our home country. So one of the things, as I said, was surgery, and fixing fractures, doing orthopedics, doing spinal surgery was kind of where I found myself. But at that time, there wasn't a university, there wasn't a vet school, there was no way that you could refer any cases to a higher level. So it was basically somebody without any postgraduate qualification at all. So I didn't think that was satisfactory, albeit it was great for development. So then I said, well, I've got to get some kind of qualification. At that stage, the only game in town for certificates was the RCVS certificate. So I managed, goodness knows how, I managed to do that remotely. So I was able to get on the certificate. In those days,
there wasn't an internet then, or it was just started. It almost just started, didn't it?
Well, it was just starting.
Not even there. Yeah,
precisely. It's almost nobody passed the exam anyway. It was that difficult.
Oh,
so
Russell,
I got myself.
I'm going to say, this is going to sound like two older people talking. I know you're a little
Precisely.
bit older than me. But I think email wasn't really there until 95, maybe.
It wasn't. It wasn't.
So you're doing a remote qualification of the RVC.
Correct.
Just imagine
Luckily,
that.
Yeah, exactly. Luckily, I found myself a supervisor. And from time to time, I would fax questions to him. And then he would maybe fax back. So the actual contact that I had...
We need to put a little thing at the bottom of the screen that says what a fax is. For the young vets that won't even know...
Precisely.
They won't even know what a fax is. They'll be like, what are they going on about?
You're making me feel incredibly old.
It's true, though. Is it true?
I don't know. You see on the films, though, don't you?
A 21-year-old might not know what a fax is.
Precisely. So a fax is a machine where you write a letter, and you feed it into a machine, and that letter goes down the telephone lines and arrives at your destination and gets printed out. Hopefully, it used to come out on paper that faded. So if you didn't photocopy it, it would fade in a week, and you wouldn't have the fax.
If only you could have done a telegram, that would have been.
Oh yeah, exactly.
Yeah, even better.
So in those days, being in a different continent was a lot further away. Let's put it that way. So once I'd got that certificate, then I felt, maybe I am qualified to take referrals, at least from my neighbouring practices. So with that, then when I came back to the UK, I opened my own practice, set up a practice from scratch, and we did a mixture of first opinion GP work, and we did referrals in orthopedics and spinal work as well. So that was having that extra sort of skill under my belt, which I never could have got if I'd have been in the UK, because there always would have been somebody better than me I could have referred cases to. I'd never have got the experience. I'd never have got the cases. So it's a little bit equivalent to, I suppose, people who work for charities. You might get a lot more surgical experience because there isn't that referral possibility. So that's why I say I was really, really fortunate in that way to have had that experience, that baptism of fire, to be kind of sink or swim, pretty much out of my depth, having to adapt and having to grow professionally, personally, all of that. So I was then in my own practice, which I worked in for 21 years and built it up to kind of not quite hospital status, but a hospital type practice. And during that time, I wasn't content. I wanted to do a bit more in the way of study. So I did a master's in orthopedic engineering. So that was a degree that I did with medics, with surgeons, human orthopedic surgeons who were training. So that was very useful because that gave me a completely different perspective on what I was doing. Because most surgeons who are putting in plates and screws and stuff don't know much about engineering. So I was like that, and I wanted to know more. So learning the biomechanics, learning the materials, learning the engineering side really was very, very useful as well. So then I was lucky enough to get advanced practitioner. And finally, the most recent thing that I did was I went back to school again, did another master's, this time in stem cells and regeneration. And the reason I did that was because I was using stem cells, I was using platelet-rich plasma, and really I felt I don't know much about this. I'm implanting these materials, I'm implanting these orthobiologics, but what are they doing in the body? How are they working? Where are they from? All of these things, I didn't really have much of a
Hold
clue
on.
about.
I'm already lost now because you said you're using stem cells and plasma-rich plasma-rich
Platelet-rich plasma.
platelets. Okay, but hold
Yeah.
on. Platelet-rich plasma. This isn't a
Yeah.
thrombocytopenia treatment. This is you're
Right.
using it locally, or what are
Right.
you doing with
Right.
it?
Okay.
And what's it look
so,
like? Is it frozen? Is it in a jelly or
Right.
something?
Right. Let me explain. So the biological products that we inject into animals with musculoskeletal diseases are collectively called orthobiologics. That's the shorthand. We call them orthobiologics. Orthopedic and biological. Okay, they're orthobiologics. And there are two main branches of that. There's PRP, the platelet-rich plasma, and there's stem cells. Okay, so we'll talk about the PRP first, if you like. PRP is normally autologous. That means that we take it from the patient, who is also the donor, or we take it from the donor and put it back into the patient, and it's one and the same animal. Okay, so it's autologous. So when we're at vet school and we learn about hematology and we learn about blood clotting and all of this, platelets are very important. But that's kind of where it ended when I was at vet school. Nobody said anything more about platelets and what else they can do. But it turns out that platelets are very complex. They have a lot of ultrastructure, and one of the things that they have is huge numbers of different growth factors within them. So yes,
But they don't even have a
absolutely.
nucleus. They're that,
They
and
don't.
they come in
They
funny
don't.
shapes. How can that?
Yeah,
I
well, if
don't.
you look at the dictionary definition and
Yeah.
it says that, a platelet is a fragment of a cell, I think that should be rewritten because when you look at platelets, they are fairly uniform in their morphology and they're very complex, and they are not just a fragment of a cell that happens to drift around until it plugs a hole in a blood vessel. These are very complex cells. I'll call them cells, even though they don't have a nucleus, that have myriad functions. It's not just the hemostatic blood clotting cascade, but within the granules, such as the alpha granules, there is a huge number of growth factors. And these growth factors are the thing that stimulates the healing. Okay, so imagine tissue has an injury. First thing you need to do is control the hemorrhage. So that's what the body does with the cascade, including the platelets. And when the platelets are there, they are able to become activated. That releases their secretome, all of these growth factors and proteins, RNAs, microRNAs, everything. But it's the growth factors that usually get the healing going. Okay. So what we do with PRP is we take those platelets and we say, well, we'll use this biological medicine for healing. That's PRP in essence. So the way that it's done is very simple. In essence, you take blood from your patient, you centrifuge it, and you take the platelets, and then you resuspend them in the autologous plasma to get a concentration of about 4 to 7 times of what the circulating blood has in platelet concentration. That PRP then is an orthobiologic in its own right, or it can be used alongside other orthobiologics such as stem cells.
So how much blood do you want from us, and how do we send it? Or how's the processing work?
This is a patient side
I
process.
see.
So, Brendan, if you wanted to do PRP, then all you need is a bit of training and a centrifuge, plus the consumables that go with it. Okay. So there are different companies that make different systems. And when you buy a centrifuge, you get trained by the company so that you can reliably produce good quality, sterile, properly concentrated PRP. We always check the PRP by putting a sample of it through the hematology machine to make sure that what we're actually injecting is PRP and has the right concentration of platelets.
So if you're talking about using it in terms of orthopedic issues. Are you talking more degenerative joint disease? Is that the main reason for using it? You're not talking fracture repairs and things like that. It's more degenerative joints is what you're looking for.
The biggest indication is going to be osteoarthritis. Quite right, Charlotte. Yeah. But it can be made into a gel.
Where would you be using the gel? Would that be a fracture site
So it's first,
post-repair before you close, or?
Yeah, that kind of thing. Exactly. All of that kind of thing. Or in the mouth when you're trying to promote, bone formation
And you're sort of waiting for the platelets to send out all those growth factors and say, come help, heal me type thing to that area.
You don't have to wait long. They do it pretty immediately the moment they degranulate. So the effect is immediate.
So you're because obviously I'm not imagining injecting into any joints anytime soon. So I could send a patient with osteoarthritis to say, let's say to you guys. You would then do this all on site on the same day. You'd make the platelet-rich plasma, and you could potentially. It sounds like you're going to be injecting it intra-articularly. Is that right? Or?
Yes. Yeah. Usually. So it can go intra-articularly, or it could go into muscles, into tendons. We can expand on that. I could tell you about how we do it here at Greenside, but we haven't talked about stem cells yet. So maybe we should talk about stem cells, and then I can put it all together so that you can get an overall
That's
picture.
the other half, isn't it? Yeah.
Yeah, exactly. So we've talked about PRP, which is the most basic, but very, very effective, very commonly used, especially in the human, because it's autologous. So it's not a drug, it's a process, effectively. It's minimally manipulated. So, the authorities like that. So let's talk about stem cells. So when we're talking about stem cells, the stem cells that we're talking about are called mesenchymal stem cells. Okay. So I'm guessing you've all heard about stem cells?
I thought you were going to test me on embryology then, because I was trying to dredge up a little bit, but then you got
we can go embryology if you want.
No, go on.
The way that we describe this to our parents is we say that these cells are the main part of the body's repair kit. Okay. So they have regenerative properties. They have other properties such as immunomodulation and anti-inflammatory effects. So obviously there's these three embryonic layers that you've just mentioned, ectoderm, endoderm, and in the middle, the mesoderm. So it's really the mesodermal tissues that we're talking about trying to regenerate things.
I was going to say, in human medicine, I know that in a lot of cancer patients, if they're having high dose chemo, they use stem cells to try and regenerate a lot of the tissue that's going to be lost. So they might give them a certain medication which helps to boost their production or to get the number of stem cells in circulation up before they try and extract them. Are you guys doing a similar thing, or do you extract them from a particular site on the animal, or where are you getting them from?
So, you don't need to for MSCs. We're talking about mesenchymal stem cells. If you take a tissue like bone marrow, there's a lot of stem cells in bone marrow, as we all know, because that's where the blood production comes from. But most of those cells are not MSCs, they're HSCs. So they're hemopoietic stem cells. There are MSCs in there, but they're very much in the minority. So you can, say, take bone marrow and you can get the MSCs from there. But that's not the most convenient place. It's not the best place.
Okay.
So the place that we normally take them from is fat tissue. And animals have excess fat tissue. And MSCs live in a particular biological niche. Okay. So there are places where they hang out. And where they hang out in the fat cells is on the capillaries. And since fat is replete with the capillary bed, outside the capillary cells, there are these cells that are stuck on the outside, which are called pericytes. And these pericytes are actually MSCs. So every blood vessel within the fat contains on the outside many MSCs.
I told her, just our experience as surgeons of fat is it's avascular, but is this because we can't see? Are we talking very tiny blood vessels here?
We're talking a capillary bed, and it's a bit of a fallacy that fat is just a storage of energy. It's just fat.
Yeah, it's still
actually
cellular.
Biologically very active, extremely active. That's a subject for a different podcast, I think. All the things that fat can do, but from the point of view of regenerative medicine, we're interested in the pericytes, which are the cells on the capillaries which supply in our case, falciform fat. So the place where we take our sample from or harvest our adipose tissue is the falciform ligament. So we do a small laparotomy. We take the fat aseptically, because once you've got the fat, you cannot sterilize it, because we're talking about a biological product. You put that in a sterile pot with some sterile saline and you ship that to the lab, and you need a special lab to extract your cells. Okay.
So that's
Then we
that
stitch it up.
fat that's midline heading towards the
Midline.
liver. And it does actually seem to have a blood supply, because when you cut it, you do
The
see
fat,
a little
yeah,
bit
exactly.
there. It's a bit more vascular.
It's the fat that gets in the way. And I
Yeah.
was harvesting fat on a case recently that had had a laparotomy previously for a foreign body, and the surgeon had very helpfully taken out all of the falciform fat. So that was a disappointment.
So, because a lot of the time, if, for example, in emergency, you're doing an X-lap and you need a wide incision, a lot of the time, yes, surgeons will be doing that. They'll be cutting out that falciform fat to get it out the way, in effect. And is there a way, I mean, potentially if this, because hopefully we think this is going to become a big thing in veterinary medicine, right? A lot of people are going to be moving towards regenerative medicine. So do you think there could be a movement in future to say, if we're going to be doing that kind of surgery, there is a way that we could store it, send it to a lab somewhere for that specific animal, so that if it was needed in the future, there is a way of us not having lost it? Does that make sense? Because like you say, it must be a disappointment when you open them up and realize that there's not as much there as you needed.
Yep, it really does make sense. And there are labs in the world that do that.
Okay.
There's one in California that you can pay for that service. So when your bitch is being spayed, you can have that fat taken and stored for the future, not used immediately.
I thought you were going to say no, because I assume the tissue's going to die. But do they do liquid nitrogen
it's like
and send it off?
Liquid nitrogen cryo storage.
It's like when people freeze their pets for hope that they're going to be brought back at some point in the future when we regenerate people or something.
Yeah, I don't know about that. Right now, what we're doing is we are using regenerative medicine to, well, let's put it this way, or maybe I should ask you, when you have a degenerative condition such as osteoarthritis, what would be a normal GP practice approach to, say, osteoarthritis?
You want to go, Charlotte?
You've got your completely dedicated owners that will want to do everything from CT scans to say exactly what are the affected joints and how badly affected are they, to orthopedic referral and for specific therapies for those joints, to the ones that say, we don't think it's that bad at the moment, we're just going to stick them on some Metacam, or they don't think it's that painful and they don't even want to use pain relief. So you have such a spectrum of clients, and you've got ones that don't want to use medicine, they just want to do hydro and rehab, and ones that want to use it. It just completely depends. I think there's not a one size fits all anymore, is there?
And I think it depends on the age, doesn't it? If you're looking at that under 5, under 6 years old, I think a lot of people are quite motivated to at the very least do some diagnostics. Where I am, because I'm not really into orthopedics, I do tend to kind of try to get them referred, and if they're young, because I'm going to say it's only going to get worse. I think for the over 6 years old, roughly, it's more likely to be weight management, help in my world, healthy diet, weight management, sensible eating, exercise, and whatever analgesics. I'm a bit cautious. We had a chat about Librela in the past. I'm a bit cautious about Librela at that age group. I mean, much happier when I got my 13-year-old plus animal, which is kind of, it's buying it another year of quality. But I wouldn't be rushing into it on a 6-year-old. Yeah. So does that give you an answer you're expecting?
Yeah. Okay. So what you've described there, the two of you, thank you, is kind of a multimodal approach. There isn't one thing that you can do for osteoarthritis. You'll normally need a combination of analgesia, most important. Adiposity management if there's overweight or obesity, weight optimization, some kind of physical therapy, possibly supplements, maybe some laser. So it's multimodal, okay? But all of those are symptom modifying. None of them are actually disease modifying. So there is this vacancy for a disease modifying drug. Because let's say you're dealing with an internal medical problem, say a chronic disease, you want something that's going to modify the disease. If it's a cancer, you'll want some surgery or chemo or whatever. You want to modify the disease. Whereas in osteoarthritis, what have we got? We haven't got anything to modify the disease until now. Now we have regenerative medicine. So if you want to actually influence the disease, slow the progression, improve what's going on biologically, within the joint, within the tissue, then you need something different from the conventional standard of care. That's where regenerative medicine comes in. Okay. So can I tell you about how we go about things in Greenside?
Yeah, sounds good. Yeah, go on.
Okay. So we find that orthobiologics and our regenerative medicine kind of exists at an intersection of lots of different areas of veterinary. It's partly orthopedic, it's partly sports medicine, it's partly chronic medical management. Okay. It's all of those things. One of the most important things when you're dealing with animals who've got orthopedic or sports medicine type or degenerative type joint diseases is to diagnose all of their problems. It's very easy to say, I've got a dog and it's got a sore elbow, therefore I'll pinpoint that, we'll x-ray it. Yes, it's got elbow arthritis, we'll target that. And that's kind of what I did when I first started. Yes, because I was taught you always have to find the seat of the lameness, find the location of the problem. You find the location of the problem. If it's elbow osteoarthritis, you know that's a grim disease, especially when it's caused by elbow dysplasia. There's not much that you can do. Let's try some orthobiologics. PRP will probably help. Stem cells will probably help more. And then you'll do that and you'll get reasonable results. But you're missing a trick because you're not diagnosing all the problems. So at Greenside, our first sort of thing that we do is try to diagnose all the problems. So we take a lot of data from stance analysis, from force plate, from goniometry, you name it, we collect all the data together. And then we will try to identify all the orthopedic problems that we have, all the arthritic joints, all the muscle strains, all the muscle tears, all the ligament problems, everything. And then once we've got that, then we will target our orthobiologics accordingly. And what we've found is that if we just target one or two joints, then they'll get better, probably, they'll improve, but then the rest of the animal will not be fixed and those problems will show up. So one of the things that we do is a very total body approach, a holistic approach to our diagnosis. And one of the most important things with medicine, as we all know, is that if you don't have a definitive diagnosis and diagnose all of the comorbidities, then you're not going to make the animal better. So
Now,
diagnosis is crucial.
you didn't gloss over it, but soft tissue, diagnosing all these soft tissue issues, how do you go about it? Because I feel like it's awful what we have, isn't it? We have x-ray or whatever. We have x-ray and we're looking for soft tissue changes in the joint. We're so crude, but you're saying that you can. How do you get tendon muscle strains? How do you work it all out?
Right. So the two main imaging modalities that we have are x-rays. And as you correctly say, Brendan, very good for joints, very good for arthritic changes, very good for osteophytes, all of that stuff, essential. So we do x-rays. And we run a package in our practice so that we don't limit how many images we can take. Once the animal has come in and is in the process, if we needed to do 20 images, we do 20 images. We want to diagnose them all. The other half of what we do is musculoskeletal ultrasound. So this is very much a minority sort of interest and pursuit. But if you can get good at doing this, and I'm in the process of learning this, if you can get good at MSK ultrasound, then you can diagnose the other half, which is the biceps strains, the supraspinatus enthesopathies, the iliopsoas strains, all of these things that occur downstream of, say, an arthritic joint. But unless you can diagnose them, then you can't target them. And what's more, if you can have somebody who's really good at MSK ultrasound, and we've got a couple in our practice, very fortunately, then you can target accurately your injections. When it comes to orthobiologic time, you can inject into those tendons precisely in real time, watching it on the screen. So that is a crucial thing.
So how much are we missing? Because obviously we don't have any tools in normal practice. Are we missing? Yeah. Is it 50% of our case? Is it, if we look, we'll find it?
It's exactly that, Brendan. Unfortunately, we're missing a lot unless we've got the skills and the kit to do it and the time. The other thing is time, because if you're trying to do a really good job, regardless of what your specialty is, let's say you're a cardiologist and I say, you've got 15 minutes to do a consult and sort out the animal. you're going to say, oh, wait, no. I need to do chest x-rays. I need to do ECG. I need to do echo. I need to do all of this. It's going to take half a day. Musculoskeletal disease is no different. Okay. You need to have the time. Okay. And our clients are so committed that they are willing for us to do that. And when you explain that we need to do a proper job, we need to do a proper diagnosis, we've got some very, very powerful regenerative tools at our disposal, but they're not going to work very well unless we've got a proper diagnosis, unless we've got all of the problems nailed down, and unless we target them accurately. So that's where, having the time and having a kind of referral practice that just does regenerative medicine really comes in. It doesn't mean to say that people who want to do a bit of regen medicine can't learn it. Definitely can, but there are different levels at which you can do it. But having the time, having the expertise, having the equipment, and being in a practice, the reason I came to this practice in Greenside Referrals in Scotland from the practice that I was previously in Singapore was because I wanted to be under the same roof as other people with the same interest as me, most notably Dr. Andy Armitage, so that we could work together, me with my surgical bent, him with his regenerative bent, put it together and hopefully, just end up with a much better situation for our patients.
Say you have a dog with horribly arthritic stifles and that's their main issue. In terms of not how you're selling it, that's the wrong way to go about it, but in terms of data and information you're giving owners in terms of saying, if I do this, this is likely to be your outcome, or this is what you can expect. What patients are you suggesting this for, and what are you expecting outcomes to be generally?
Okay, so outcomes are generally very good. So if you want to have a paper on that, there's Armitage's paper from, I think it's 2023, where Andy looked back at 245 cases that had been kind of written off. They'd had the conventional treatment, they were unresponsive. So these were all cases, 245, that were desperate for something to be done because conventional medicine had not sorted them out. And if you look at his data on that, on every parameter, they improved. So, and there's multiple sort of parameters that are measured as endpoints for judging whether or not the treatments worked. If you, it's like every discipline, if you do a really good job of your regenerative medicine, then the outcome will be, on the whole, pretty good.
When you say, our conventional medicines are just helping to ease the pain, right? Whereas your regenerative medicine, you're hoping to sort of reverse some of the osteoarthritic change and the damage that's been done. That's the point of the medicine, is it? Oh, wow.
Exactly. So osteoarthritis is notoriously difficult because it's always described as being incurable, painful, progressive. Okay. And when you're faced with the disease that is incurable, progressive, and painful, then that's not a good situation. Now, that doesn't mean that we can always regenerate the cartilage, and that's a difficult thing to prove, but we can definitely improve the comfort and definitely slow the progression. So that's osteoarthritis. When you're talking about things like tendinopathies, we can prove sonographically that on day one, it looks like this, then we inject and then we follow up. And on day X, it looks like something else. So you can actually, with musculoskeletal ultrasound, you can actually show the progression of your disease or the improvement, where the fiber pattern returns, the healing occurs, the swelling goes, and normal tissue architecture appears to be restored. So yes, now, absolutely. So going back to that question that you had there, Charlotte, with that stifle osteoarthritis. Mm-hmm. If you've got stifle osteoarthritis, then you might have an underlying cause such as cruciate disease. Let's assume that's been treated or you don't have it. Even then, there will be other parts of the body that will be affected. Probably the iliopsoas will be affected. And because you're offloading one joint, you're probably putting more force on another joint. So unless you look at the elbows, the shoulders, the hips, the lumbosacral spine, you're missing something. So we need to look at all of those areas, and wherever there is pain or a restricted range of motion or some other thing on the clinical picture, then we're going to miss something. So the clinical examination is absolutely crucial. And that is backed up by the imaging. In a way, the musculoskeletal ultrasound becomes an extension of the clinical examination. So in sports medicine, you will notice that the clinicians are very, very good at palpation and detecting problems. A bit more like the physiotherapists. Physiotherapists are really sensitive and brilliant with their hands. When you watch them work, they will pick up things that vets will never pick up. So in one sense, you need to have one foot in that camp, learn from the physios and bring that into your clinical practice. But yes, you will always find. And the other notorious one is foreleg lameness. You may have elbow osteoarthritis, but you almost always have shoulder problems downstream of that. Okay. And it's referred to as a shelbow lameness. And a lot of the time, you're not certain, is it the elbow? Is it the shoulder? So because you've got stem cells and there isn't really a limit on how many stem cells you can get out of your sample, we just order enough stem cells to do as many areas as we need to. So if we're injecting the elbows, we'll normally find something in the shoulder that needs to be injected. So doing the whole job is much more important than pinning down and finding, the one problem that you think it is.
Could I backtrack to, so for the patient, you do the test in the morning, let's say, the stem cell you get, it looked like 5 grams. I just quickly had a look at that abstract from the study you quoted. I think you get a small piece of the fat, falciform fat. And then what's the processing time for getting that ready? Are you literally getting your patient injected up that afternoon, or is it you get them back 2 weeks later?
No. Okay, let me explain the stem cell processing. So PRP, you can do at one sitting, no problem, patient side. There are patient side processes that you can do for bone marrow concentration or sometimes smashing up fat and injecting that. We'll leave that to one side. What we do is we use autologous fat, send it to our stem cell lab, which is in Coventry, Cell Therapy Sciences. They have got a well-practiced process that they've done thousands and thousands of cases where they take that fat, digest it down, and extract out the cells. And then they have to identify the cells, make sure what they've got is viable, passage the cells through about 4 passages until they end up with the culture that is pure, viable, and it takes about 4 weeks. And after about 4 weeks, then they can send you your orthobiologic, which is the vial of the cells, which is millions of cells, at least 2.5 million per ml. And then they keep some back in their cryo storage so that if you need another sample or need some next time, you don't have to harvest again. Okay. So then they come back after 4 to 6 weeks. Then we do our implantation under sedation, which is inject all those parts that we found that need injection. And then we repeat that after 3 months.
Is that the same for the PRP as well as the stem cells?
Normally it can be. Normally with PRP, you want a shorter interval if you're just using PRP. The way that we do it is on the day of the implantation, we have the vial of our MSCs, and then we do PRP. And then just before we inject them, we mix them because they have a super additive effect. They augment each other. And one of the ways that they do that is because the platelet-rich plasma contains fibrinogen, which becomes fibrin when it gets into the body and forms a 3-dimensional mesh. Now, one of the things I didn't tell you about MSCs is they like to be attached to something. And one of the ways that they're extracted from the sample in the lab is because they are the cells that stick to the plasticware. So when they're in the dish in the lab, you can wash away the other cells and the MSCs will stick to the dish because they like to, in their biological niche. Remember I said that they were stuck to the blood vessels? They like to have a surface, a 3-dimensional thing to attach to. So if you can inject at the same time into the same joint, say, your PRP and your MSCs, then the PRP clots, provides the growth factors, all of that, and then the MSCs can attach to that 3D fibrin network, and that keeps them in the place where you've injected them for longer so that they can do what they do.
If you're using stem cells, for example, you'd give an injection and then another again 3 months later. You say it's a 6-year-old patient. Are you expecting to ever have to repeat that? Or is that hopefully that does the trick for those joints? Or how long are you expecting a treatment like this to help for?
Typically Typically, it lasts 18 months. But what we do is we keep them in our pipeline. So we follow up our patients every several months. And when they show signs of beginning to deteriorate, we offer the client and say, well, we could re-inject. We've still got some stem cells in the lab. Shall we do another implantation in whatever joint? And it may be that, another joint has become affected, or you may need to make adjustments, but you've already got your orthobiologic reserve, and then you can do that as needed after 18 months, 2 years, or whatever it happens to be.
I sort of get the feeling that platelet-rich plasma is probably an easier sell because we take some blood, we spin it, we get what we need, we inject it. Whereas saying that even a small laparotomy incision, it's still a GA, an incision into the abdomen to get the falciform fat initially. Do you find that there's such a significant improvement in patient outcome to do the stem cells that you're pushing people to say, well, not pushing people, wrong words, but to say, this is definitely worth it in terms of pros versus cons, because the outcome of using those stem cells in addition to the PRP is going to be so significantly more? Is that sort of the standpoint you come from?
Exactly. So most of our patients, most of our clients will choose to go the whole hog. There may be circumstances where we don't think it's necessary to have stem cells, in which case we can do the PRP. And there may be some cases where maybe we don't have the financial resources and we're looking for an effective but less expensive way of going, in which case we might just do PRP on its own. But preferably, if you can do both together, then you'll get a much better effect.
So from the client's point of view, is it like a 1-inch incision there for the laparotomy to get the falciform fat? I mean, it's pretty little, or not?
It depends who does it. I tend to do a longer incision than my colleagues, but it's going to be a short. I mean,
couple of inches.
Yeah, it might be not dissimilar from a bitch bay incision, but the way that we do it is we follow the zero pain practice process, whereby it's very comfortable. It's infused with local analgesic. We're using opioids, we're using non-steroidals, we're using paracetamol, we're using everything all combined in a multimodal analgesia. And it's almost never that we get any problems with that. So that is not a big deal. When you think animals are sent for elbow surgery, arthroscopy, total hip replacement, compared to all of those, this is a very small intervention. So it's not a big deal at all.
Obviously, if there's any general practice vets that are listening and thinking this sounds really interesting, but it's something they would refer cases for rather than consider doing themselves, what would you say are the ideal subset of patients that should be looking to be referred? Does that make sense? So are you saying anything with a lameness, or are you saying animals with a known degenerative condition or a known muscle issue? Or, when would you say to a GP vet that patient is great to refer for regenerative medicine?
Okay, so all of the above. However, if you wait until things are desperate and nothing else has worked and all of the joints have fallen apart, and then you're expecting a miracle, then you're not probably going to get a miracle from any modality at all. So let's take an elbow case, like say elbow dysplasia. If you can get that case young, say 1 year of age, and start them on the process of regenerative medicine, rather than arthroscopy, rather than surgery, rather than a life of severe misery from horrible osteoarthritis, if you can get in there early, then you'll have much better results. So more and more, we're getting younger and younger patients diagnosed with osteoarthritis. We know that because there are so many situations where young dogs will develop OA. And in that situation, getting them in early for regenerative medicine and starting them on that is going to be way better than waiting until they're end stage. I know I referred to Andy's paper earlier where 245 cases were pretty much end stage. Even so, they improved. And that is true. That is the case. But you're going to get better results if you get in there early. So earlier is better. I guess unknown lameness, yes. Most of the time, vets are pretty good at having an inkling of where the problem is, whether it's a cruciate that needs surgery or whether it's an elbow dysplasia or whether it's hip dysplasia. Most of the time, but not always, they'll come with a reasonably close diagnosis, but we will put the finishing touches on that. We will go into more detail. We'll go into more depth. We've got more time. We've got, different facilities, and we will unpick everything that can be unpicked.
And would you say if a patient, I don't know, had ruptured its cruciate and, standard practice needs a TPLO or a TPLO has been suggested, would you suggest that this sort of regenerative medicine is something that is used in the follow-up from that TPLO, or is it started at the
Yes,
same time as the surgery, or when would you be suggesting?
can be.
Oh,
Yeah,
wow. Okay.
can be. When we do cruciates, we always put PRP in at the same time.
Yeah.
Okay. So yeah, why not? It's easy to do.
Mm.
You've got your centrifuge right next to you, so it's a sensible thing to do. So I've done a lot of cases where I've done like elbow surgery, and at the same time as doing that,
Yeah.
it's a very small thing to go and harvest some fat. You know, compared to say doing an elbow arthroscopy, it takes another 10 minutes to harvest some falciform fat, and then you can get that started quickly as well. So all of those are situations where you can use your regenerative medicine. Which, yes, if you want to refer, then obviously we welcome referrals at Greenside. That's what we do all day, every day is referrals in regenerative medicine. If somebody wants to know more about regenerative medicine, there is a book out you may have seen. I'm the author. We can put a link in the show notes if you like.
Yeah.
So if there's
Yeah, for
anybody who
sure.
wants to know more about this, I've written a manual which tells
Perfect.
you basically what
Yeah.
we've discussed in a lot more depth, but it's very digestible because I didn't want to write a scientific book. I wanted to write a practical manual so that people could pick it up,
Yeah. Great.
use what's in there, and get started with regenerative medicine. Because as you said earlier, Charlotte, regenerative medicine is the future. It's been touted as being the future for 10 or 20 years, but we have such a lot of
Mm.
orthobiologics available now. I think it's no longer the future. I think it's now the present. I think the future is bright because we are going to get more experience. We're going to get better and better, and we're going to refine our orthobiologics. And I think the future is for regenerative medicine is going to be very exciting. But even without the future, the present, what we have now,
Yeah.
is effective, and it's already kind of the future is already here, if you like. We're doing it, and we're doing it every day, and we're
Mm.
making a difference. And the most important thing, we're making a difference to animals' lives. We're helping them to have a disease modifying modality, a living medicine. We're not just giving them
Yeah.
drugs. We're not just palliating their conditions. We're actually doing something
Mm.
that is positive and, if you like, healing.
And from a client perspective as well, I mean, I've got a dog, and thinking how much nicer it would be to think, getting her on something like that sooner rather than later, and thinking about PRPs and stem cell injections for the years before she desperately needed pain relief and all these medications that she's going to need completely long term. From a client perspective as well, I mean, I'm definitely getting a shift in people saying, oh, I don't want my dog on long term medication. It's not natural. We want to go down therapy, more natural routes rather than medicine. And I think this is a really clever, amazing medicine, and that it's not, like you say, it's autologous. It doesn't feel like a drug. And I think in a way that's so much more saleable to clients, and they can get on board with the idea so much more because it's using the great things that that animal already has. It's just putting them into the place where they're most useful, isn't it? So it's super interesting.
Exactly. I couldn't have put it better myself. On that subject, we
Mm.
do have a lot of vets, animals that come to us, a lot of veterinary nurses bring their animals to us, a lot of veterinary physiotherapists
Yeah.
bring their animals to us for regenerative medicine.
Obviously, you'll only be chatting from sort of your practice's point of view in terms of costs and what you guys offer. But in terms of just so GP vets can give clients an idea roughly of what they could be looking at if they go down the regenerative medicine route. If, for example, you were to do a package where you were to do diagnosis of all the issues, PRP and stem cells in one patient, say you had a Labrador, for example, is there a rough cost that you would give to owners as a guidance, or to referring GP vets as a guidance, and is PRP significantly cheaper, etc., just so people have a rough idea of what they could be looking at?
Yeah. So PRP is cheaper if you just have that on its own. Generally, we're talking for the package, and we do a package. We do 3 levels of package for our orthobiologics, depending on how many cells are cultured. So the main thing is how much of the orthobiologic you need. And it goes, I don't normally deal with the financial side. I think it goes something like 6, 7, 8,000, something like that. Those are the packages. So compared to what you'd normally do with surgery, it's kind of about comparable, but you're treating the whole animal. You're treating all the joints. You're storing up some orthobiology for future. You're following up your patient. You're measuring all of those parameters that I've said. So the actual detail that we go into with the diagnosis and the care is pretty impressive, if I say so myself.
And you're buying patients time, I guess, as well, aren't you? You think those animals that would otherwise have got to a point where they get, I don't know, hit 10, 11 years old and their osteoarthritis becomes unmanageable. If they can invest in regenerative medicine earlier on in their life, and as you say, potentially reverse or slow the process of that arthritis in those joints, you could buy them, in effect, you're investing in buying them another few years of being comfortable, right? Which I think is an amazing way to talk to clients about it. Because it is a big outlay for people, isn't it? But thinking of it as an investment in their longevity is a sensible way to think about it, I guess, isn't it?
Charlotte, you're a very good advocate for this area. I like what you said there. So, like I say, I could talk for a long time on this.
Perfect. And if anybody has any particular questions or advice cases or anything like that, do you guys run a service where you're happy to give people advice, like a normal referral clinic? Or?
Absolutely. Yeah. Just email us at Greenside. You can find the email from our website, and we'll be happy to help.
Before we finish completely, we've done the orthopedics and joints. I think that's the main part of the business. But there are other applications, aren't there? Because we touched on feline gingivitis stomatitis complex. I don't know how the treatment works for that. I guess, I don't know. Tell me, but is there other ones that you think you've seen good results on?
For myself, my experience is really just in musculoskeletal disease because I've come from orthopedics. So the diseases that normally end up in front of me are going to be joint diseases, muscle, tendon, all that sort of thing. Yes, that stomatitis complex, a lot of people are trying to use MSCs for that because MSCs are immunomodulatory. And since this is a problem to do with the immune system, a malfunction of the immune system, one of the things that MSCs can do when they get into the body is they will sense what's going on, okay? Because it's a living medicine. It's not like giving a drug where the drug has one pathway, one receptor that you're trying to affect. MSCs aren't like that. MSCs will go into a body and they'll have a look around and sense what's going on and find out what's needed. We need to upregulate this. We need to downregulate that. We need to change the way these macrophages are behaving. So cases like stomatitis, other inflammatory things like inflammatory bowel disease, there's experimentation on a product which I think will come out for inflammatory bowel disease, anal furunculosis, these kinds of things. Even renal failure may be a target for MSCs. So there's lots of different ways. Once your algorithm starts picking up stem cells, you'll be bombarded with this because there is just so much information, so much research everywhere. But the main thing in the human and in the veterinary is orthobiologics, and it's mainly by using MSCs. In the future, we may not even need to use the MSCs because we might be able to use the products that come out of the MSCs, which are the membrane-bound exosomes that come out of there. So sometimes you hear a lot of research talking about exosomes rather than cells. So we may not even need the cells. We may be able to take the cell products and use those. So there's loads of things that we can do. We might be able to genetically modify the cells so that they'll do more of what we want and less of what we don't want. There's all sorts of things in the future that might happen. But even without that, if we just use what's available now, we'll be getting way better results because for the first time, we've got a genuine disease-modifying osteoarthritis therapy.
Yeah, really cool. Thank you.
Sounds good. Sounds great. I'm glad I know about it now. I was telling Russell before, I had a client, and I think this is AI related because we're really seeing this now. So they go on AI, they find out what's the best treatments. So she came to me and said, what do you think of this, and this? And one of them was regenerative medicine. And I just kind of said, I don't think I know, we're doing that much at the moment. No, I was even more negative, actually. I probably said, I don't think that's really taken off yet or something. But obviously, if that had been, tomorrow, so I think clients might start pushing it because of AI and the information they're getting.
Honestly, we get more referrals that are client-led than we actually do from veterinary practices.
There you go.
Yeah. So it's one of those things that the clients know about, which is why a podcast like this is so crucial, because nobody likes to be in a consulting room The client comes in, they've been on Google, they've been on AI or whatever it is. They
Yeah.
bring you something and they say, what do you think of this? And you don't know anything about it. And it happens to us all.
Yeah.
So hopefully now, if somebody comes along and says, well, I've heard about platelet-rich plasma, I've heard about stem cells, I've heard about regenerative medicine.
The really interesting thing as well is, especially with the platelet-rich plasma, there are a lot of vets out there that are really keen for further studies and to further their skills. And I think, people that are keen for certificates or to be doing something slightly different in their practices, platelet-rich plasma sounds like something that's fairly achievable for a lot of vets. If you can get confident with your joint taps in terms of injections, and if you can get confident with diagnosing the issues in the first place, yes, your general practice vets are probably not going to be at the point where we're going to be doing MSK ultrasound. But, if you can definitively say in these joints or in the area of the spine, lumbosacral issues in these patients, we think platelet-rich plasma would be great. I think that one, it's an easy sell to clients, and two, it's something that we could really be investing in our patients, which is amazing, even without always potentially needing to refer. But obviously it's a bit of a way off, but it's quite interesting to think that people could be doing that in practice now.
Absolutely. That's how most of us started off. It's very much the kind of, the simplest way, the entry level sort of regenerative medicine. Get some PRP under your belt. Yeah, for sure. I hope I gave the impression that I'm enthusiastic about regenerative medicine. I don't know whether that came across. I feel that it's sort of my career has kind of, everything that I've done in my career has converged at this point and brought, whether it's been engineering, whether it's been stem cell studies, whether it's been surgery, whether it's being in Hong Kong, whether it's been in Singapore, all of those things, being in the VOA, all of these things, they've all converged to this point where I'm in Greenside referrals and very proud to be here, just doing regenerative medicine every day. It's an absolute sort of delight and pleasure to be able to help animals in this way.
Okay, we don't know about you, but we loved every second of that.
And we're really keen to hear back from you, hearing your thoughts about what you think about regenerative medicine. Do you think you'll be starting it? Is it something you might recommend to clients?
Do you think that you'd be looking at platelet-rich plasma? Are you interested in stem cells? What do you think? Give us your opinions. Are you already doing it? Maybe you're one of the practices that is already doing it. Please let us know. Remember, you can send us your voice notes on WhatsApp. You can message us on social media. Or remember, you can start a discussion with us on our blog post. So you can get that link from our socials. So have a little look. We have some really great discussions on there, so please do get in touch. We'd love to hear your feedback and comments on this topic especially, so please do get in touch.
Just to add to the pain excitement, we've got, I don't know if it's going to easily match what we've done with Russell Chandler, because we've got another really, really good guest, someone that most of you I think know about. I think you'll hear me cheering when we interview him. That's how excited I was.
Yeah, it's going to be really, really good. So again, we can't wait to release it, but we're going to keep you in a little bit of suspense. So keep tuned to our social media and the pods where we'll be giving you some more information about that in the few months to come. So, but for something that's going to be coming up a little bit sooner, next weekend is our weekend of rest, but tune in on the 14th of June for our first 2-week takedown of the month, where we'll be covering everything from bradycardias and AV blocks, when careers get a bit complicated with complaints, and all things joint supplements, plus much, much more.
Yeah, we're looking forward to it already. Just to say, keep your comments coming for content ideas. We do use them. Sometimes the content might come in a few weeks down the line because we've got such a packed recording schedule. But don't think we're not listening. We really are including a lot of the things that you're bringing up for us. Until then, it's bye from me.
And bye from me. Take care.
Is intended for licensed veterinary professionals and is provided for educational and discussion purposes only. Whilst it's publicly accessible, it is not intended as advice for pet owners.
The views shared are based on our own clinical experience and interpretation and do not replace individual clinical judgment. We accept no responsibility for decisions made based on this content, and all cases should be assessed on an individual basis.
Any references to medications, treatments, or products are made for educational discussion only and are not intended to promote or advertise veterinary medicines to the general public. Veterinary medicine should only be used under the direction of a prescribing veterinary surgeon and in accordance with UK veterinary medicine regulations.
This podcast may include paid partnerships or sponsorships. These do not influence our clinical opinions, and any sponsored content will be clearly identified.